Welcome. This is the New England Journal of Medicine. I'm Dr. Michael Bierer. This week, July 4th, 2024, we talk about stress ulcer prophylaxis during invasive mechanical ventilation, new therapies for hereditary angioedema, tissue factor-directed therapy in cervical cancer, and normalization of C1 inhibitor in a patient with hereditary angioedema, a review article on acute abdomen in the modern era, a clinical problem-solving article on aggregating the loose threads, a medicine and society on a case for the Medical Civil Rights Act, and perspectives on academic freedom in America, on water pollution, health, and medicine's duty to engage, and on To Forgive, Divine. Stress Ulcer Prophylaxis During Invasive Mechanical Ventilation by Deborah Cook from McMaster University, Hamilton, Ontario, Canada, and co-authors. Critically ill patients are at risk for stress-induced gastrointestinal ulceration, which may cause upper GI bleeding. Consequently, patients in the intensive care unit typically receive acid suppression to prevent GI bleeding, most commonly a proton pump inhibitor. A network meta-analysis that summarized all evidence from randomized trials showed that acid suppression reduced the risk of upper gastrointestinal bleeding among patients in the ICU, but had no effect on mortality for any prophylactic agent. However, harm with proton pump inhibitors could not be ruled out regarding the risks of healthcare-associated pneumonia and C. difficile infection. This study evaluated whether proton pump inhibitors are beneficial or harmful for stress ulcer prophylaxis in critically ill patients undergoing invasive ventilation. In 68 ICUs, 4,821 critically ill adults who were undergoing invasive ventilation were randomly assigned to receive intravenous pantoprazole or matching placebo. Clinically important upper GI bleeding occurred in 1% of patients receiving pantoprazole and in 3.5% of patients receiving placebo. At 90 days, death was reported in 29.1% of patients in the pantoprazole group and in 30.9% of patients in the placebo group. Patient-important bleeding was reduced with pantoprazole. All other key secondary outcomes were similar in the two groups. Among patients undergoing invasive ventilation, pantoprazole resulted in a significantly lower risk of clinically important upper GI bleeding than placebo, with no significant effect on mortality. Samuel Brown from Intermountain Medical Center, Murray, Utah, writes in an editorial that a critical care clinician's job includes administering timely and tailored antibiotics, expediting appropriate surgery, supporting a patient's beleaguered body and mind until they are ready to recover, and preventing complications in this vulnerable state. This is surprisingly strenuous work, even if it is often appropriately protocolized. The aphorism, "An ounce of prevention is worth a pound of cure," persists because it feels true. So when trial data suggest that an ounce of prevention may actually kill you, it cuts hard against the grain, which brings us to the question of gastric acid suppression among patients undergoing mechanical ventilation in the ICU. In their trial, Cook and co-authors found a small but clear reduction in the risk of clinically important gastrointestinal bleeding at 90 days, the primary efficacy endpoint, with pantoprazole as compared with placebo. In addition, the findings regarding death at 90 days, the primary safety endpoint, and the secondary endpoints of ventilator-associated pneumonia and C. difficile infection were similar in the two groups. Although firm conclusions cannot yet be drawn, the baseline severity of illness did not appear to be associated with a difference in either bleeding or mortality. So what do we know from the collective data? Proton pump inhibitors slightly but significantly decrease the risk of important gastrointestinal bleeding and have a decent chance of slightly decreasing mortality in less severely ill patients during mechanical ventilation. Moreover, we can be certain that proton pump inhibitors do not decrease and may slightly increase mortality in severely ill patients. Given the challenges that are inherent in trials involving severely ill patients in whom no meaningful mortality benefit is likely, this is all we will know for the foreseeable future. Efficacy and safety of donidalorsen for hereditary angioedema by Mark Rydell from the University of California at San Diego, La Jolla, and co-authors. Hereditary angioedema is a rare disorder characterized by episodic, potentially life-threatening swelling caused by kallikrein-kinin dysregulation. Long-term prophylaxis can stabilize this system. Donidalorsen, an antisense oligonucleotide, specifically reduces prekallikrein expression. In this Phase 3 trial, 90 patients with hereditary angioedema were randomly assigned to receive donidalorsen or placebo once every 4 or 8 weeks. The primary endpoint was the time-normalized number of investigator-confirmed hereditary angioedema attacks per 4 weeks, attack rate, from week 1 to week 25. The least squares mean time-normalized attack rate was 0.44 in the 4-week group, 1.02 in the 8-week group, and 2.26 in the placebo group. The mean attack rate from week 1 to week 25 was 81% lower in the 4-week group than in the placebo group, and 55% lower in the 8-week group than in the placebo group. The median reduction in the attack rate from baseline was 90% in the 4-week group, 83% in the 8-week group, and 16% in the placebo group. The mean attack rate during weeks 5 to 25 was 87% lower in the 4-week group than in the placebo group, and 60% lower in the 8-week group than in the placebo group. Donidalorsen, administered every 4 weeks, resulted in an improvement in the least squares mean total score for the change at week 25 on the Angioedema Quality of Life questionnaire, in which scores range from 0 to 100, with a score of 100 indicating the worst possible quality of life. That was 18.6 points better than that with placebo. The most common adverse events were erythema at the injection site, headache, and nasopharyngitis. 98% of adverse events were mild or moderate in severity. Donidalorsen treatment reduced the hereditary angioedema attack rate, a finding that supports potential prophylactic use for hereditary angioedema. Oral sebetralstat for on-demand treatment of hereditary angioedema attacks by Mark Rydell from the University of California, San Diego, La Jolla, and co-authors. Approved on-demand treatments for hereditary angioedema attacks need to be administered parenterally, a route of administration that is associated with delays in treatment or withholding of therapy. In this Phase 3 trial, 136 participants at least 12 years of age with type 1 or type 2 hereditary angioedema were randomly assigned to take up to 2 oral doses of sebetralstat, 300 milligrams or 600 milligrams, or placebo for an angioedema attack. The time to the beginning of symptom relief with both the 300 milligram dose and the 600 milligram dose was faster than with placebo, with median times of 1.61 hours, 1.79 hours, and 6.72 hours, respectively. The time to reduction in the attack severity with the 300 milligram dose and the 600 milligram dose was faster than with placebo, with median times of 9.27 hours, 7.75 hours, and more than 12 hours. The time to complete resolution was also faster with the 300 milligram and 600 milligram doses than with placebo. The percentage of attacks with complete resolution within 24 hours was 42.5% with the 300 milligram dose, 49.5% with the 600 milligram dose, and 27.4% with placebo. Sebetralstat and placebo had similar safety profiles. No serious adverse events judged to be related to the trial agents were reported. Oral sebetralstat provided faster times to the beginning of symptom relief, reduction in attack severity, and complete attack resolution than placebo. In an editorial, Rohan Amaratunga and Hilary Longhurst from the Auckland Hospital, New Zealand, write that the designs and results of the two trials by Rydell and co-authors offer reassurance that both sebetralstat and donidalorsen can safely and effectively be administered as a patient-led treatment, reducing the burden on medical services for acute conditions. Neither sebetralstat nor donidalorsen was directly compared with existing treatments. More evidence is needed to assess the efficacy of sebetralstat in treating laryngeal angioedema or gut angioedema, in which the absorption of the drug may be impaired. Nevertheless, sebetralstat therapy appears to reduce the kallikrein level enough for the therapy to be effective within 15 minutes after administration, and has a longer half-life than the bradykinin B2 receptor inhibitor icatibant. On the assumption that the efficacy of sebetralstat is similar to that of currently available treatments, an orally delivered agent may be more acceptable to patients and may enable earlier treatment. Donidalorsen prophylaxis also reduced kallikrein levels to below the 60% functional threshold, which is associated with relative freedom from hereditary angioedema attacks. Thus, the pharmacokinetics data and early clinical findings from the two trials by Rydell and co-authors suggest that the efficacy of each agent will be at least similar to that of agents in current use. The goals of management of hereditary angioedema have shifted from the preservation of life and the relief from unbearable pain to the complete control of the disease and the normalization of patients' lives. With a new highly effective prophylactic option with an acceptable side effect profile and an orally administered on-demand option for breakthrough attacks, treatments for hereditary angioedema are closer to meeting these new goals. Normalization of C1 inhibitor in a patient with hereditary angioedema by Nicholas Peters from Oxford University Hospital's NHS Foundation Trust, United Kingdom, and co-authors. Nearly all cases of hereditary angioedema are caused by mutations in SERPING1, the gene encoding C1 inhibitor. C1 inhibitor is a multifunctional protein produced in the liver that regulates the kallikrein-kinin system at multiple points. An infant with genetically confirmed hereditary angioedema and low C1 inhibitor levels, but without previous episodes of angioedema, underwent liver transplantation for biliary atresia, an unrelated condition. Liver transplantation led to normalization of the C1 inhibitor level and function. To the author's knowledge, this represents the first patient to be potentially cured of hereditary angioedema. Tisotumab vedotin as second- or third-line therapy for recurrent cervical cancer by Ignace Vergote from the Katholieke Universiteit Leuven, Belgium, and co-authors. Recurrent cervical cancer is a life-threatening disease with limited treatment options available when disease progression occurs after first-line combination therapy. In this Phase 3 trial of tisotumab vedotin as second- or third-line therapy in patients with recurrent or metastatic cervical cancer, 502 patients were randomly assigned to receive tisotumab vedotin monotherapy or the investigator's choice of chemotherapy. The median overall survival was significantly longer in the tisotumab vedotin group than in the chemotherapy group, 11.5 months versus 9.5 months. Results that represented a 30% lower risk of death with tisotumab vedotin than with chemotherapy. The median progression-free survival was 4.2 months with tisotumab vedotin and 2.9 months with chemotherapy. The confirmed objective response rate was 17.8% in the tisotumab vedotin group and 5.2% in the chemotherapy group. A total of 98.4% of patients in the tisotumab vedotin group and 99.2% in the chemotherapy group had at least one adverse event that occurred during the treatment period. Grade 3 or greater events occurred in 52% and 62.3%, respectively. A total of 14.8% of patients stopped tisotumab vedotin treatment because of toxic effects. In patients with recurrent cervical cancer, second or third line treatment with tisotumab vedotin resulted in significantly greater efficacy than chemotherapy. Acute abdomen in the modern era. A review article by Selwyn Rogers, Jr. from the University of Chicago and Orlando Curtin from Jefferson Health, Abington, Pennsylvania. Acute abdominal pain is one of the most common symptoms in patients presenting to the emergency department and accounts for 5 to 10% of all emergency department visits. Pathophysiological conditions that lead to surgical interventions in such patients are mainly gastrointestinal obstruction, hemorrhage, ischemia, and viscous perforation. Acute abdominal pain can be diffuse or localized and is associated with, but not limited to, the following disease processes: perforated viscus, peptic ulcer disease, mesenteric ischemia, acute cholecystitis, appendicitis, diverticulitis, pancreatitis, and intra-abdominal hemorrhage. The need for emergency general surgery is an independent risk factor for postoperative complications and death, indicating the severity of the condition. Therefore, timely diagnosis of acute abdominal emergencies is essential. The primary care physician, emergency department physician, or advanced practice provider, nurse practitioner, or physician assistant, is often the first clinician to evaluate a patient with acute abdominal pain. These non-surgical clinicians may administer analgesic agents and order laboratory tests and diagnostic imaging. Concurrently with or after diagnostic testing, they decide when to request surgical consultation. In this review, the authors explore, first, the effect of administering an analgesic agent during the initial evaluation of acute abdominal pain. Second, the essential role of imaging, particularly in older adults. Third, the importance of timely surgical consultation. And finally, cognitive biases that can lead to false conclusions and incorrect diagnoses. Aggregating the Loose Threads, a clinical problem-solving by Sonia Davey and co-authors from Brigham and Women's Hospital, Boston. A 58-year-old woman presented to the emergency department with progressively worsening dyspnea and dysphagia. Her symptoms had begun 22 months earlier, when dyspnea on exertion had developed. After symptoms had been present for 6 months, the patient saw a pulmonologist. Pulmonary function tests showed a reduced diffusion capacity for carbon monoxide, as well as reduced total lung capacity, vital capacity, and residual volume. CT angiography of the chest showed extensive acute emboli in both lungs, with evidence of right ventricular dilatation. She was admitted to the hospital and received a diagnosis of antiphospholipid antibody syndrome. In the year after hospitalization, the patient's dyspnea abated. However, dysphagia to liquids, but not to solids, developed. She also had fatigue with activities such as brushing her teeth and making her bed. Both these symptoms progressively worsened over several months, and she presented to the emergency department approximately 16 months after her initial hospitalization. A neurologic examination was abnormal, with axial and symmetric proximal limb weakness, a pattern clinically consistent with a myopathy or a neuromuscular junction disorder. Further neuromuscular evaluation, including muscle biopsy, led to the diagnosis of sporadic late-onset Nemeline myopathy. This myopathy is a rare but probably underdiagnosed disease. In a large case series, the mean age at the onset of symptoms was 52 years, and the mean time from the onset of symptoms to diagnosis was 4 years. Most patients present with weakness in the proximal limbs and axial muscles, that is, weakness of neck, flexors, and paraspinal muscles, along with dyspnea and dysphagia, and more than half of patients have an IgG monoclonal gammopathy. Delivering Justice, a case for the Medical Civil Rights Act, a Medicine and Society article by Leonora DeLuey and co-authors from the Medical Civil Rights Initiative, Boston. Each year, approximately 60 million people in the United States have contact with police officers, and up to 10 million have interactions with correctional officers while being held in U.S. carceral institutions. However, only in Connecticut, since the passage of the Medical Civil Rights Act in 2023, are law enforcement officers required to immediately summon emergency medical care for a person experiencing a health crisis while in direct contact with them or in their custody. In other U.S. jurisdictions, in the absence of such statutory protections, lethal delays in the provision of emergency medical care may occur, both in the field and in correctional settings. On average, an estimated 7,000 people die in custody each year. However, the number who have poor medical outcomes is currently unknown. In many cases, these medical crises start well before a person reaches a carceral institution or even makes contact with an officer. Barriers to health care have led to the widespread misconception that deaths in these circumstances result largely from misconduct, or that officers have sought to maintain unclear laws governing the delivery of medical care. In actuality, officers, too, face the adverse consequences of our current legal frameworks. Until other jurisdictions in the United States enact the Medical Civil Rights Act, countless people will continue to die needlessly, many while pleading for access to care that is not received in time. Academic Freedom in America. In support of institutional voices, a perspective by Evan Mullen from Stanford University, California, and co-authors. As debates over what constitutes free speech play out in U.S. newspapers and courtrooms, those of us practicing medicine in university settings have been wrestling with the parameters and implications of its cousin, academic freedom. Stanford University, where two of these authors work, has long faced controversies over this principle of the American Academy. Indeed, the notion of academic freedom to speak out on issues of public interest can be traced to the once notorious Ross Affair at Stanford at the turn of the 20th century. The 1900 Ross Affair involved Stanford professor Edward A. Ross, who was known for publicly voicing divisive opinions, for example, advocating for expelling Japanese immigrants from the United States. Concerned that his views would sully the reputation of the university she'd founded with her late husband, Jane Stanford urged President David Starr Jordan to fire Ross. Jordan resisted, but Ross resigned amidst the ensuing controversy. More recently, in August 2020, Scott Atlas, a senior fellow at Stanford's Hoover Institution and former faculty neuroradiologist, joined the Trump administration as a COVID-19 advisor. Atlas's public pronouncements disputing the efficacy of masks in protecting against viral spread and supporting a policy of allowing the virus to spread to generate natural herd immunity drew condemnation from 98 other Stanford physicians and researchers expressed in a public letter, but only after the university decided not to speak publicly on the matter. But should the institution have remained silent when lives were potentially at stake? In the author's opinion, both U.S. history and precedent suggest that the university's reticence was misguided because it failed to consider three important distinctions outlined by scholarship on academic freedom, including the distinction between absolute from relative freedom, between expertise and opinion, and how intramural expression differs from extramural expression. Downstream. Water Pollution, Health, and Medicine's Duty to Engage, a perspective by Shira Abeles from the University of California, San Diego, La Jolla. Every day, Millions of gallons of raw sewage flow through canyons that cross the U.S.-Mexico border and collect in the Tijuana River, where the sewage frequently overwhelms wastewater treatment facilities and flows directly into the ocean on San Diego's southern coast. On June 27, 2023, San Diego County Board of Supervisors proclaimed a local emergency in response to this decades-old issue that has recently escalated to become a crisis. The sewage dissipates enough in the ocean for the beaches of Central and North San Diego County to remain clean, but beaches in the less affluent southern part of the county have been perpetually closed because of contamination. In addition, residents of South Bay are exposed to foul-smelling air from the polluted river and ocean and contaminated ocean spray. The U.S. International Boundary and Water Commission monitors the volume of effluent crossing the border and into the Pacific Ocean, and the San Diego Department of Environmental Health and Quality has established a robust monitoring program for fecal contamination of ocean water, using droplet digital PCR testing for Enterococcus, levels of which are regularly more than 100 times as high as those considered safe for recreation. Nonetheless, researchers and clinicians don't have an adequate grasp of how this uncontrolled flow of sewage into the ecosystem affects the health of people living nearby, downstream, and downwind. Compromised wastewater infrastructure and water quality aren't uncommon, including in the United States. Clinicians need to be aware of the ways in which environmental factors are contributing to disease as part of a framework that incorporates social determinants of health. To Forgive, Divine. A perspective by Victoria Johnson from the University of Illinois, Chicago. When Dr. Johnson walked into the hospital for a 28-hour call shift as a newly minted senior internal medicine resident, she had no idea that she was about to make a serious mistake. About halfway through her shift, Dr. Johnson was called to admit a patient who had fallen several days earlier and had developed cauda equina syndrome due to spinal fractures. He had also presented with other problems, including new-onset atrial fibrillation, a urinary tract infection, and a possible pneumonia. Dr. Johnson didn't know much about cauda equina syndrome. This was Dr. Johnson's first real-life case, except that it was a surgical emergency. Unfortunately, per neurosurgery, the patient's paralysis was likely to be permanent, so surgery was to be delayed until his other conditions were stabilized on the medicine service. Dr. Johnson did know how to manage atrial fibrillation. She dutifully started the patient on rate control medication, ordered an echocardiogram, and calculated his CHADS-2 VASC score, which indicated that he was at substantial risk for stroke and a candidate for anticoagulation. Dr. Johnson decided that a heparin drip would be best, since its effects would quickly subside should he need to go to surgery. Later that night, Dr. Johnson couldn't escape a nagging feeling that she was missing something, so she ran the case by a resident friend who was working in the emergency department. Dr. Johnson felt reassured until the resident friend asked if there was an epidural hematoma complicating the fractures. Dr. Johnson hadn't even known to worry about that. She quickly double-checked the CT and MRI reports, and 5 lines down the long list of significant findings on the MRI T-spine report, there it was, suddenly, glaringly obvious, epidural hematoma. It was about 3 a.m. Panicking, Dr. Johnson immediately switched off the heparin drip. She remembered that the antidote was protamine, but she had never given it before, so she called the pharmacist for help. Dr. Johnson felt her credibility disintegrate when she told the pharmacist what was going on, and the pharmacist responded in that horrifyingly quiet, controlled way that tells you something awful has happened. Before rounds, Dr. Johnson asked the attending to step into the hallway, and she told him about her error. Dr. Johnson was mortified, expecting the worst, but his response was even-tempered and action-oriented. He asked about the patient's progress and suggested re-imaging the hematoma. Fortunately, Dr. Johnson's patient's outcome was not worse as a result of her error. He recovered as well as could have been expected. As for Dr. Johnson, she was unmoored. Her shame was bottomless. Later that week, when just Dr. Johnson and her attending were walking down the hall of the ward, he told her about a mistake he had made when he was a resident. Dr. Johnson felt less alone and felt liberated a bit from the weight of her shame. In our images in clinical medicine, a 67-year-old woman presented with a 1-week history of dyspnea and cough. The physical examination was notable for discolored, dystrophic fingernails and edema in the legs. A thoracentesis was performed, and 1.1 liters of milky yellow fluid were removed. Findings from analysis of the pleural fluid were consistent with a chylous effusion. A diagnosis of yellow nail syndrome was made. Yellow nail syndrome is a rare disorder characterized by xanthonychia, yellow nails, lymphedema, and upper or lower respiratory disease, such as bronchiectasis, pleural effusions, or chronic sinusitis. The clinical features may occur asynchronously and abate spontaneously, making diagnosis challenging. In another image, a 101-year-old man with a 5-month history of urethral catheter use had sudden onset of turbid, greenish-yellow urine. CT showed protrusion of the catheter through the bladder wall, and a vesico-ileal fistula was seen on laparoscopy, shown in a video at NEJM.org. Bladder fistulas are rare complications of urethral catheters. The risk of this complication is increased in the context of inflammation, trauma, or cancer. The fistula was resected, the ileum and bladder were repaired, and a suprapubic urinary catheter was placed. This concludes our summary. Let us know what you think about our podcast. Any comments or suggestions may be sent to audio@nejm.org. Thank you for listening.